What's up, guys? My name is Omar, aka Daher Radiology, and today we're going to be talking about radiology call. So let's get started. Alright, so the first thing we're going to be talking about is the hours of call. During call, you're working from 5 p.m. until 8 a.m. the next morning at our institution during the weekdays. And during the weekends, they are 12-hour shifts. Then after that, someone else takes over, etc. Usually you're working both Saturday and Sunday. That is very variable for a whole bunch of different institutions. I've seen different structures such as night shifts, where people are working 7 days in a row, except that they're working shorter shifts, but only during the night period. I've seen 2-person call, I've seen 1-person call. This is all variable. So essentially, I won't get too in depth into this, but the hours are usually in some form of 12 or 24-hour shift, depending on where you are and what you're covering. For us, we cover 3 hospitals, 1 person for 5 p.m. till 8 a.m. After 8 a.m., you get to go home, you get to leave, you don't need to review anything, you're kind of absolved of any of the clinical duties, and you get to go home and sleep after your post-call. We'll talk about that later towards the end of the video, but I just wanted to give you kind of a rough idea of how our call is scheduled, and also know that it's very variable depending where you are. This is similar to when you're a staff radiologist. You're usually covering the same time hours. However, you may or may not be reporting the cases as preliminary reports because your residents might be doing that. You may be signing them off as you go or in the morning time after the resident has gone, and you're basically finalizing the reports for them to be fully signed off. So that's the hours of call. Next up, we're going to be talking about the responsibilities on call. So as a radiology resident, I alluded to the fact that we're covering 3 different hospitals where I am, and during which time from 5 p.m. till 8 a.m., any requests that come in from the emerge or inpatients are protocoled by the radiology resident, us, and we basically see whether or not the scan needs to be done urgently, with contrast, etc., depending on the clinical history, and then we get the scans done and we report them as a preliminary report. Most of the time, your responsibilities on call are to essentially prioritize emergent and urgent scans that need to be done overnight. A lot of the times, these scans come from the emerge themselves to try and rule out something that needs immediate intervention. That could be a whole slew of different things, from ischemia to dissection to aneurysm rupture to stroke. So depending on your institution and what your hospitals cover, you may be responsible for a whole gambit of different modalities and different types of scans depending on the service that's asking for them. At our institution, absolutely everything is covered by the radiology resident on call, and they are responsible for 3 different hospitals, such that if anything urgent is required, they will do it overnight. The other types of responsibilities that a radiology resident might have overnight would be to arrange for MRI. So there are certain emergency indications to have an MRI, such as cauda equina, and you may have to kind of be an administrator role to kind of fit in a schedule with the MRI techs and make sure that the spot is available for someone to get it overnight so that they can be operated on as soon as possible if it's a true emergency. This is a bit of a deviation towards radiology in general, because you are acting a bit more as an administrative role in that sense, but it is still an important part of the job, because that patient needs to get the scan at the end of the day. You're also trying to coordinate who needs to come in if they're on-call technologists, such as ultrasound if they're not in 24/7, or MRI, as I mentioned earlier, so that you're basically mediating the scan to happen, or facilitating the scan, I should say. Other than that, your responsibilities would be to hand over things that don't get accomplished overnight to the next person that's on during the day, depending on the modality that they're performing, as well as sometimes doing teaching and multiple other responsibilities that you may have overnight. A couple of those things are variable, such as helping other residents read an X-ray scan for an NG tube placement or endotracheal tube placement, and really just helping out in general for people with imaging modality type questions. All right, so the next thing I'm going to talk about is protocoling. Protocoling is something that radiology residents do on call, and is very difficult to explain to someone what that actually means. There are some resources out there that help to explain protocoling, but it is very specific and takes a little bit of time to understand when and why you should be using contrast in your scans. So, as you may know, there are different types of CT scans where there's non-contrast, there are IV contrasts, there are oral contrasts, there's gadolinium in MR scan for contrast. So there are different types of scans out there. It's not as simple as just ordering a CT scan for ruling out something from the emerge. So basically you need to know when and why you should use it, and with that comes risk of contrast itself. So contrast is not just this substance that everyone can have, and it has its own repercussions. So someone who has kidney function deficits that may not be able to actually excrete the contrast itself needs to be taken into consideration, as well as radiation exposure for protocoling scans that may affect reproductive organs, for example, in someone who's young. These are all things that need to be considered when protocoling. So, for example, if you're looking for a stone in the renal system, you probably just need a non-contrast scan. And that doesn't require IV contrast, doesn't require oral contrast, so that is a scan that would be done without contrast, and you need to know that before doing the scan itself, because it may actually obscure your view of seeing a stone. There are scans that definitely need contrast, but only IV. So when you're looking for ischemia, you need to know that the bowel is enhancing appropriately. Within that, there are also different phases of scans. The arterial system, the contrast is in the arterial system versus the portal venous system, versus a delayed scan where you're seeing if there's any contrast, maybe in the urinary system. So the phases are also part of protocoling, and telling the techs when to scan the patient is another part of your job. All in all, protocoling is a very complex subject. We'll leave it at that for now, but it is another part of the radiology resident's job overnight. So next up, we have the pager and answering pages. So as any resident is aware of, you are attached to the pager when you are on call. For radiology residents, the pager is a way to get a hold of us, and it is basically to talk about a difficult scan or something that needs more history, or a service that's trying to arrange something that's not normally done overnight, for example, or they may just want to discuss a case with us. So the pager is a big part of call. It can be very tedious because it's constantly going off, and to be honest with you, the pager is one of the worst parts of call, because you're kind of constantly hearing the pager, and it means that someone else is trying to get a hold of you. All the while you're trying to report scans and trying to keep the workflow going, but you're constantly being interrupted that way as well. It is a part of any resident's overnight call, but I would say in radiology, our pager is constantly going off and the work is constantly flowing. So it is something to keep in mind, but it is something that is particularly heavily a part of on-call radiology in today's overnight call. It's not like it used to be 30 years ago, where the pages were seldom and you were kind of only paged about really important scans. Nowadays, more and more imaging is being done overnight, and it's becoming quite a busy night for radiology to assist other services in trying to triage different types of emergencies. So that leads us to actually reading reports. So this is the bulk of a radiology resident's job overnight, is to actually read the scans. So all these scans depends on your, facility and your institution and what things you do overnight and what services are available in your hospitals. For us, we have pretty much every service available overnight. So this could include things such as stroke, all the way to mesenteric ischemia, bowel obstruction, all the way to obstetrics and gynecology emergencies, urology emergencies, neurology emergencies, cardiac emergencies, really anything that can be intervened on overnight. So reading scans is the bulk of everything. You are, as a radiology resident, giving the down and dirty of a scan, basically. So in some institutions, if you're a junior, you may just be able to get away with saying there is no aortic dissection, but then become more senior, you're kind of pulling out more formal reports and getting more adept into getting all of the small details into a report done for the clinician to see. That being said, our job really is to maintain the patient safety and to get out the diagnoses as fast as possible. So reading overnight is very much dedicated to the fact that you, as a radiology resident, are trying to find the life-threatening disease that the patient may have and to make sure that the correct services are involved as soon as possible. Reading is very tedious, but it is made more difficult because of the pages and people are trying to interrupt you constantly overnight. But it is our primary job to report the scans. I have many other videos about different aspects of radiologists and the scans that they read, so if you want to check those out, you're more than welcome to do so, but we'll leave it at that for now. The next part of the call structure is going to be relaying information. So when you find something that is life-threatening or needs to be communicated to the referent service, you need to call them. So let's say there's a ruptured aneurysm and you need to call the service that ordered the scan and tell them, hey, there's this ruptured aneurysm, you need to see the patient now, and you basically get to document that you've spoken with this person and they're taking care of the situation. Usually this comes with the responsibility of letting everyone know and the appropriate people know. So if there's a dissection, you need to know the difference about, calling cardiac surgery versus vascular surgery. And of course, that's a very detailed talk on its own, but it is something that you learn as a radiology resident overnight. The next thing is administrative work. So this is a tough subject for radiology residents because you're trying to learn on call and you're trying to survive on call by mitigating all of the emergencies that are happening overnight. But you're kind of stuck doing administrative work as well, which means that you're organizing the MRIs, you're trying to organize the techs to come in to do urgent scans, you're trying to organize things to be done in the morning versus now. So this is more of an administrator role that I think is not talked about as much but needs to be addressed and is part of your responsibilities overnight. Finally, we're going to be talking a little bit about post-call. So once you are done your shift at 8 a.m. at our institution, you go home. All of the reports have been sent to your staff. They're all pre-limbed, so you don't have any more responsibilities. You get to go home, go to sleep, relax. You've been up, you've been stressed, you've done your day's work and don't need to worry about anything. Once you are revived and rejuvenated, you get to see all of your edits to your reports If there's been any discrepancies, your staff usually tell you, let you know, you learn from these situations, and you improve as you go on. Of course, as a radiology resident, you're not perfect. None of us are, none of us should be. This is the reason why we're training. So hopefully you get to learn from your mistakes after you're rejuvenated and you're not completely zombied, because no one can learn after a long shift and stressful shift like that. That is all I have today, guys, for call, and I hope you enjoyed this video. If you have any more suggestions, as always, leave a comment below. If you like this video, give me a thumbs up, and don't forget to hit that subscribe button. We'll see you in the next one.